Thanks everyone for listening tonight. I'm going to go through a bunch of different things related to general fertility assessments, the process of IVF, and a few other bits and pieces along the way there. But as Brooke said, very happy to answer any questions. So just wanting to acknowledge the land on which we're all meeting, the Awabakal Worimi people, the traditional custodians of the land. So who am I? I'm a fertility specialist. My office is in the Junction, and I'm part of what we call Newcastle Fertility Specialists. So that's a team of 4 female fertility specialists. So that's 4 out of the 5 Genea doctors. We see all aspects of fertility and are very comfortable treating any kind of fertility-related concern. So I trained mostly in Newcastle, then went to Sydney for a few years and did a laparoscopic fellowship and some more training in infertility, and then moved back to Newcastle, and I've been in practice for well over a decade. We're getting to close to 15 years now. So things that we're going to go through tonight, the concept of fertility, the impact of age and ovarian reserve on your fertility, what are some baseline investigations that might be ordered for you either by your GP or a fertility specialist, what are some fertility treatments that we commonly do, some frequently asked questions, some success rates for our particular clinic, Genea Newcastle, and then answer any other questions that come along. So what is infertility? It is defined as the inability of couples to conceive a pregnancy after a year of unprotected intercourse. That doesn't mean that everyone has to try for a year before they come and see a fertility specialist. We do have some general age-based guidelines on when people should seek assessment from a fertility specialist. We generally say that if the woman is under 35 years, it is reasonable to see a fertility specialist after 12 months. If the woman is over 35 years, then it is very reasonable to come along and see us after 6 months of trying. But I will also premise that by saying those are not absolutely set timeframes either. And if there's anything else that is either a blatant sort of problem that might be affecting fertility, say lack of periods, known substantial endometriosis, a known other medical condition that might affect your fertility that you've already been aware of, or if you just want some reassurance and just to know that basics have been looked at, I see couples well before those timeframes reasonably often as well. So when we talk about pregnancy rates, the reason why that sort of 6 months and 12 months came into effect was because if you look at a couple's chance of conception over a year or 12 months, by the 12-month mark, about 85% of couples have achieved a pregnancy on their own. So if the woman is young, so less than 35, that's why we sort of have that 12-month rule. But again, it doesn't need to mean that that's what you have to do before you see us. Age is one of the biggest impacts on your chance of pregnancy. And that's just something biological that we can't get around. Women are born with all of the eggs that they're ever going to have. The number of the eggs decline with time and the quality of the eggs decline with time, and therefore the chance of pregnancy declines with time. So you can see in this graph that a 22-year-old has a 25% chance of conception per month. By the time that you get to 36, that's dropped down to 15%. And by the time that you get to 40, it's down sort of at about 7%. So the rapid rate, there's a fall right from your early 20s, but it becomes a lot more rapid in the second half of the 30s and definitely into the 40s. And you can see on the graph there that it says that there's a decrease in egg quality, egg quantity, an increase in aneuploidy risk. Aneuploidy means a abnormality of the embryo or the pregnancy, so say like trisomy 13, 18, Down syndrome, that kind of thing, and an increased overall miscarriage risk as the woman ages. When we look at the age of women having children, it has increased substantially the age where women are actually trying to have children, and that's been a steady increase since the sort of 70s, where the lowest it used to be is sitting around about age 22, 23, and now we're well into the 30s for most women to be trying to conceive for their first pregnancy. This is a picture of eggs in a woman's ovary at different ages. So you can see at birth, there are absolutely prolific amounts of eggs in the woman's ovary. At 25 years old, that's declined. And at 50 years old, that's almost negligible. So all women are born with the eggs they're ever going to get. It starts mostly in most women at about 6 to 7 million. By birth, that's already reduced to only a couple of million. By puberty, we're down to about 200 to 500,000. And then as you age, you just keep either using up eggs or losing eggs just by cell death. Only about 200 to 500 of those women's eggs ever ovulate over a lifetime. So there's an enormous amount of eggs that go unused and die on their own accord. Sorry, not sure why it's not moving on to the next slide. I'll just try this. Yeah. So men, does men's fertility or does men's age affect their fertility? Yes, it does, but the impact is substantially less. Most men in their 20s and 30s, their fertility is maintained reasonably well. It does start to decline from around 40 years, but the rate of decline is substantially lower, and most men in their 40s and even 50s will still be able to conceive a child. It just might reduce the time frame to achieving that child or need to have some more interventions. And even men in their 60s and 70s can sometimes conceive children. There is, however, an increase in risk of pregnancy loss as the man ages, and that's probably a similar type of phenomenon that the older the woman's eggs, the higher the chance of miscarriage. The older the sperm, the higher the chance of miscarriage as well. So what are some basic things or some common things that can affect fertility, and what might we do to investigate those? So if we're looking at female factors, there's tubal damage. So either women who've had previous surgery, so ectopic pregnancies, or other surgery for things like endometriosis or previous infections can damage your tubes. How will we investigate that? We can either do what we call a tubal patency test. One of the common ones and one of the ones that we do for our patients is called a HSG, where we run dye through the fallopian tubes and check that it comes out the other end. Or sometimes we combine it with laparoscopic surgery if we think that there's something else that we need to do, or we're trying to check for things like endometriosis. On that note, endometriosis can affect your fertility, and either ultrasound and or a laparoscopy is a common way to investigate that. Anovulation, or lack of releasing the eggs, is something that we see reasonably commonly in our practice. A common reason for that would be PCOS or PCOS, and definitely an ultrasound and some blood tests help to us to further identify whether that might be what's going on. And then less commonly, we do see patients who have premature ovarian failure or premature menopause. So these patients are still in what we would consider normal reproductive age group. So women in their 20s and 30s who have already gone through menopause and don't have any eggs of their own left. Which is obviously a fairly devastating diagnosis for someone so young. And the way that we would diagnose that is with some hormone profiles. With men, the main thing that we need to explore in terms of trying to work out whether there's a male factor in fertility is a semen analysis. Based on those results, if there are some abnormalities, there's often further tests that the man needs to do, particularly blood tests, but the baseline test for men is a sperm test. About 30% of couples, though, will come and we can't actually find a cause of their infertility, and we call that unexplained. So what would we do in most females who come to see us for a fertility assessment, we want to do some prenatal assessments. The ultimate goal for all of our patients is pregnancy, so we want to know that their health is optimized for pregnancy. So we might do things like checking vitamin D, iron stores, thyroid function, those kind of things, and optimizing that before pregnancy. And immunity to specific diseases such as rubella and chickenpox. We might check for ovulation. We might start to do investigations for other causes of infertility, such as genetic causes or endometriosis. We would usually always assess what the woman's ovarian reserve is, and there's a blood test called an AMH level where we can get an insight into the woman's egg reserves compared to other women of her age, and then tubal patency testing. So as mentioned, the things that we would do in prenatal assessment: iron, vitamin D, thyroid function, a blood count. We may look for fasting sugars and a diabetes assessment, immunity, a basic infection screen, and then all of our patients are offered something called genetic carrier screening. So that's looking for genes that if both a female and the male carries those genes, then it gives that couple a higher chance of a baby being born with that specific genetic condition. So all of our patients are offered different options of genetic carrier screening, which they may or may not decide to do. In terms of ovulation, some of our couples come and they are very clued into when they might ovulate and when they need to try to have intercourse to conceive. Some patients either are less aware of their most fertile window or actually can't pick that because either their cycle is irregular or they don't get symptoms associated with that. Basically, though, we know that timing intercourse to be a day or two prior to the egg coming out gives the highest chance of achieving a pregnancy. And the reason is that the egg is the rate limiting factor in the whole thing. The egg will live for about 12 to 24 hours within the female body after release. The sperm that have entered the female reproductive tract can live for up to 5 to 7 days. So what we want time for the sperm to actually travel up to the end of the fallopian tube to be waiting for the egg to be released. And that's why timing intercourse a day or two before is actually the most fertile days. So for example, a very stock standard 28-day cycle, the woman is likely releasing the egg about day 14. So her most fertile days to time intercourse would be about days 12 and 13 because they're the couple of days before the egg comes out. A lot of the period tracking apps these days can help a little bit with that. A lot of women use the urine testing strips. They are great if you get positive, so they have a really good reproducibility if that you get a positive result. A negative result is not overly helpful with those tests because there's a high false negative rate. Some women, as I said, get lots of signs of ovulation, change in cervical mucus, pain, those kind of things, or just have a very regular cycle and so are able to pick that. But there are other ways that we can do this besides just using your app or the urine testing strips. And one of the ways that we do have on offer is what we call ovulation tracking. So Genea offers all patients 2 cycles of bulk billed, so no out-of-pocket cost ovulation tracking, and that's using blood tests to actually identify exactly when the woman's most fertile days are, so that that couple knows that they were timing intercourse absolutely correctly. So that referral can come from either your GP or your fertility specialist. You don't have to come to the fertility specialist before accessing those 2 rounds. And we will also then check your other hormones throughout the cycle. So a week after we see the peak of ovulation, we check for the progesterone rise, which indicates that the egg has definitely been released. And then we also do a test to see for pregnancy about a week after that as well. It is also helpful that those nurses are very skilled in doing this, and sometimes a patient of mine will be doing ovulation tracking and the nurses are seeing something that they know might represent a problem, and then they'll direct them back to me and just say, hey, FYI, these were the results this month. I'm not sure if you want to do anything different for this patient at this stage. So this is an example of a tubal patency test. The X-ray on the side is what we call a HSG. So the big, bright, almost T shape in the middle is the woman's uterus, and that is being filled up with radio-opaque dye. And then on either side, there is spillage out into the abdomen of the radio-opaque dye, implying that it's gone through their fallopian tubes. Our office does that with X-ray. It can also be done with ultrasound in some units, or it can be done at the time of a laparoscopy. The upside to that test is twofold. One, it rules out another problem, so it proves that the fallopian tubes are open and working well. The other benefit is that it actually does increase the chance of spontaneous pregnancy for about 3 or 4 menstrual cycles following it. So it's not just an investigation, it's actually a treatment as well. It's a quick procedure. It sometimes causes some crampy pain, but it's usually very well tolerated and very quick. Other things that we can do to test ovarian reserve. So ultrasound can count the antral follicles. So the antral follicles are the small follicles that are sitting in the ovary waiting to develop. Counting those at the start of a woman's cycle can give one indication of her egg reserve. If we are concerned that a woman might be going through premature ovarian failure, we would do a hormone profile about day 2 to 3 of the cycle to look for their levels of FSH, which is raised if they are peri or postmenopausal, and an AMH or an anti-Müllerian hormone, which again gives us another indication of a woman's egg reserve. So a few things about an AMH. It can be done anytime in the cycle. There's been various times where people have said, oh, you have to time it at specific times in the cycle. That's been fairly disproven, so we don't try and get a woman to time it at all. We usually get her to do it at the same time as we're doing all of her other investigations, which reduces how many tests she has to have. It can be affected by being on hormonal contraception. So if a woman is on the oral contraceptive pill and has an AMH and it comes back low, it may be falsely low. And what we would sometimes do in that setting is actually get the woman to stop contraception, wait for her natural cycle to come back, and therefore the pill is no longer having an effect, and then remeasure it, because usually it will be reduced by up to 20 to 30%. It's useful to determine the timing of menopause and the pool of eggs within the ovaries. It can help us guide response and prognosis in things like IVF cycles. There isn't any kind of Medicare rebate for the actual test, but you can use the receipt for it for the New South Wales government $250 rebate, but it does not estimate the chances of natural conception, and it does not measure egg quality. It is a quantity test only, not a quality test. This is just a general graph that shows you how AMH can be reported. Within the 2 dotted red lines would be the normal range. The median or the average is the solid red line. Reduced ovarian reserve is underneath the dotted red line, and then high ovarian reserve, and we've got probable PCOS there, although not all patients who have a high AMH have PCOS, is above the red dotted line. Things that we can look for, besides what we've already discussed: endometriosis, fibroids, which are benign growths of the muscle layer of the womb, endometrial polyps that can reduce the chances of a pregnancy implanting and increase miscarriage risk, uterine scarring from previous procedures within the uterus, such as curettes, and genetic causes of infertility. Men, I've mentioned semen analysis, but there's also genetic testing and hormonal testing. So semen analysis should be performed after at least 2 days of complete abstinence for the man. So 2 days of absolutely no ejaculation, but no longer than 7 days. There is quite significant fluctuation of sperm up and down in men normally. So all men have an increase and decrease in their sperm production over time. And so when we see one sperm result, if there are some abnormalities, we will always repeat that about 6 to 8 weeks later to make sure that that is actually a true result. It's offered through Genea, and things that might cause abnormal results, lifestyle factors such as smoking or heavy alcohol use, testosterone or steroid use basically reduces or switches off sperm production. Any kind of significant illness, so a severe viral infection, any other major medical episode that a person has can affect momentarily their sperm production, and obesity. So let's talk about a few fertility treatments that potentially are on offer. So there are various different types of surgery that can be offered depending on the situation. So for a woman, the common things would be things like treating endometriosis or treating uterine fibroids, although not all fibroids need to be treated. Only about 5 to 10% of women who have fibroids actually end up with a problem from them, and only a percentage of those would need actually anything done about them. In terms of men, some men need surgical sperm retrieval because they either have a blockage for the sperm coming out, or they make such small amounts of sperm that we actually have to get it directly from the testes. And men who've had a history of a vasectomy may choose to go down the path of a vasectomy reversal to try and re-establish their fertility and therefore be able to try for spontaneous pregnancy. When we talk about assisted reproductive technologies, that encompasses basically all of the treatments that can be done at Genea. So ovulation induction, that doesn't always need to be done through Genea, although sometimes it is. Intrauterine insemination, IVF, ICSI, which is just a way that we fertilize the eggs in the IVF process, and then pre-implantation genetic diagnosis. So this is where we are testing the embryos for a genetic condition and trying to have that condition not be passed on to the patient's offspring. There are other fertility options that we talk about on a regular basis with patients, such as egg freezing or sperm freezing, donor sperm or donor eggs if that's necessary, and surrogacy in quite specific circumstances. So IVF is sorry, that should read IUI at the top. So IUI is where we introduce sperm directly into the uterus at the most fertile time for the woman. So basically what we do is we do blood ovulation tracking for the woman. We find out her most fertile day, put in a speculum in the vagina, just like when you're having a pap smear, a tiny thin catheter into the uterus, and essentially inject the sperm directly into the uterus. The pregnancy rates are not amazingly high. They're quoted somewhere between about 5 to 10% per attempt, or 35% over a 6-month course of treatment. But mostly we wouldn't do more than, say, 3 attempts at IUI before we moved on to something else. So apologies for the heading there. That should read intrauterine insemination, not IVF. We can do this with either the patient's partner's sperm or donor sperm, as long as the sperm has suitable parameters for intrauterine insemination. So why might we need to do IVF? There's a multitude of reasons why we do IVF these days. There's male factor infertility, female factor infertility, if a patient wishes to use donor sperm, so a single or a same-sex couple, unexplained infertility, patients with known genetic conditions wanting to undergo pre-implantation genetic testing, and patients with a history of recurrent miscarriage.
Sorry, I don't understand.
Sorry, my other computer in the room is trying to listen like Siri. I'll just try and turn that off. So I'm just going to go through the steps of an IVF cycle with you now. So the first step is to stimulate the ovaries. So what do we do? Basically, every single month, a woman's ovaries choose a whole group of eggs in each ovary. That's whether she's on the pill, not on the pill, trying for pregnancy, not trying for pregnancy, a whole group is chosen. Normally, only one of those wins the race and gets released and ovulates. The rest of the eggs in that month die and are lost. What we're trying to do in IVF is not just get one egg out of that month, we're trying to get as many eggs out of that month. So we're actually not using up your eggs any quicker than what your own body was going to do. We're just saving the ones that were destined to be lost that month anyway. It usually starts from a period. Women who don't have periods, we have ways and means of getting around that. But 2 days after the bleed comes, you start injections of a hormone that grows the egg. So it's a synthetic version of one of the hormones that your brain sends to your ovary in a normal setting. It's just at a much higher dose than what your own brain would do to try and get more than one of those eggs to develop. So that's a daily injection. The nurses do teach you how to use that. 5 days later, you start a second injection, and that second injection's job is to stop you ovulating, because what we don't want is to grow all the nice eggs in the ovaries. The brain sends a signal to release them, and we lose all of those eggs into the tummy. So basically, one medication to grow the eggs, one medication to stop them being released before we want to. We then do a blood test and an ultrasound to see how the body is responding. And in the top ultrasound pictures, the one in the middle is an ovary before we did anything. And then the next two are an ovary as it responds and grows. So the little black circles in the ovary get bigger, and they're called follicles. And we hope the bigger ones of those contain an egg. So we count how many of those follicles there are, and we measure the size of them. And that as well as the hormone levels, then decide when the eggs are ready to be collected. So this is what a ovary might look like. So the top one is a situation where a woman is just trying for pregnancy on their own, where only one of the follicles has responded and grown to a size where it will ovulate, and the other follicles in that month have stayed small. In an IVF cycle, so the bottom ultrasound picture is where more than one of the follicles has grown and gotten bigger, in the hopes of getting more than one egg out of that ovary. So once we see that the eggs are ready, you're told a really specific time to take a final medication called the trigger. The trigger will mature the eggs, and then we have an egg collection 36 hours later. So the trigger is always at night. So say, for example, we told someone to take the trigger tonight at 7 o'clock. Their egg collection would be Friday morning at 7 o'clock in the morning. So how do we do the egg collection? Basically, as the ovaries grow and get bigger in an IVF cycle, they're sitting just on the other side of the top of the vagina. Most of our patients, this procedure is done in what we call our minor procedure room in Genea. Sometimes some patients need to be done in the actual operating theatre in Lingard. What we do is the patients who are in Genea just get some sedation through a drip in their hands, so they're awake but just feel a bit groggy and sometimes don't remember it. The patients who are in the operating suite will actually be put to sleep. We then use an ultrasound through the vagina. We use a little bit of local anesthetic at the top of the vagina, and then a small needle goes through the top of the vagina into the ovary and basically takes the fluid out of all of those follicles in each of the ovaries. Typically, it says here typical egg collection procedure takes about 20 minutes. That would include getting you ready at the start and getting you all sorted out at the end. The actual procedural time frame is probably 5 to 10 minutes in the middle of that. So patients who are being done in Genea will have some medication through a drip. That's fentanyl and some midazolam. They'll also have some oxygen prongs in their nose, and we will measure heart rate and blood pressure through the procedure as well. So this is our procedure room. So there's a bed where the patient lies. We have an ultrasound machine. This photo is a little bit old, so our ultrasound machine is now much, much, much smaller. And then over on the side, there is what we call a crib. So that's basically where the scientists will be working with their microscope to look through the fluid and find the eggs within the fluid that we collect. So the eggs is the largest cell in the human body. When we collect it, it looks like the picture on the side that looks like a fluffy cloud. So the egg is the black circle in the middle of that. And then all of those other cells around it are what we call cumulus cells. So they're protecting and supporting cells of the egg. So when we collect the eggs, we can't tell their maturity when we first collect them. We don't know their quality. We don't know anything about them in that room when we're collecting them. We just know the number of eggs. Not all follicles will contain an egg. We anticipate that most follicles over about 14 millimeters in size will, but that does not always mean that they all do. And sometimes smaller follicles produce an egg as well. And not all of the eggs that we collect will be mature when we collect them. So the day of the egg collection, you will find out exactly how many eggs that we collected. And
Okay, I found this on the
sorry,
web for the day of the
stop.
egg collection. You'll find out exactly
Sorry.
how many eggs that we collected and check it out.
No, I do not want you over there, Siri. Sorry, I don't know why that keeps coming on. Apologies. So for the patients who are undergoing egg freezing and not actually trying to achieve a pregnancy at that point, that's the day that the eggs are frozen. And in fact, that afternoon, one of the scientists will call you and tell you how many of the eggs were mature and therefore able to be frozen. If you're doing IVF, that same day, your partner will give a sperm sample, or if you're using donor sperm, that's the day where we will thaw the donor sperm. Most men will produce that sample in what we call the green room at Genea, which is a discrete room where they can produce a sample, and that's usually after the patient, the egg collection is completed. If we need to do a surgical sperm extraction for the male patient, their procedure usually follows straight on from the woman's egg collection. So then we add sperm. So this is a picture of sperm. I don't know if you can see my cursor, but this is a sperm here, this is a sperm here, etc. So this is unwashed a semen sample. So all of the other little dots and things are other cells and debris and things like that within the semen. So this is the sperm actually moving. So you can see that some of the sperm are really moving around. Some of them are just twitching a little bit and some don't appear to be moving at all. But then there's lots of other cells. So we then wash the sperm. And this is what it looks like when we've just got the washed sperm. So mostly that then leaves the motile sperm, not the immotile sperm, and gets rid of all of that other debris. So this is what we would add to the eggs to try and get the eggs to fertilize. So if there's a surgical sperm extraction needed directly from the testes or the epididymis, then that procedure is done by all of our fertility specialists as well. These sperm can only be used to inject directly into the egg because they usually haven't completed their maturing, and there's usually not enough quantity to just mix them with the egg. So how do we actually then put the sperm and the eggs together? There are two ways. One is what we call conventional IVF, and that is where we have normal sperm parameters. And that's where we basically put sperm and eggs in a dish together and we let them fertilize on their own. And then they're checked for fertilization 16 to 18 hours after they're put together. The other option is ICSI, or intracytoplasmic sperm injection, and that's where we take one mature egg and one moving sperm, and we inject the sperm directly into the eggs. To do that, those supporting cells that surround the egg that we saw in that earlier slide need to be removed. So this is a picture of ICSI. So the round circular thing, that's the egg. And there's the needle going into the egg to inject the sperm directly into it. Why might we use ICSI? If there are poor sperm parameters, so what we call male factor infertility, if we are planning to test the embryos for a specific genetic condition, so something called PGTM, and that's because in conventional IVF, where we just mix them together, sperm end up being stuck around the outside of the embryo. We don't want any other genetic material to be stuck around the outside of the embryo if we are wanting very, very specific testing of the embryo's genetics. And so we don't want any sperm stuck around the outside. So we will use ICSI in that setting. If a couple has had IVF and they had poor fertilization rates with just mixing the sperm and the eggs together, we will swap to ICSI. And we just put a single sperm into each egg. So what happens to the fertilized eggs? They then sit in an incubator. Genea has special incubators called Jerry. Only Genea units in Australia have Jerry. No other IVF units in Australia will have this. Jerry's introduction, and Jerry was made by Genea's research and development arm called Genea Biomedics. It's an extremely high-tech incubation system where the embryos are left undisturbed the entire time that they are in there, and time-lapse photography is used to do all of the checks. Since we introduced Jerry into Genea, our success rates have gone up again. And the picture is of the first Jerry baby, so the first baby born with embryos that we incubated in a Jerry incubator, and that was actually at Genea Newcastle. It was Dr Mafumwi McElveen's patients, and that's because Newcastle is a really good well-established small unit, and so we were the first ones to test the incubators and therefore got the first baby. So then they sit in the incubator and they grow. And basically it is cells dividing and dividing and dividing. So the first 3 days is just what we call the cell stage, where we get just cellular division. Day 4, the picture on day 4, you can kind of see that it goes from individual circles to kind of a blob, and that's called compaction. So that's where all of the cells sort of look like they're compacting together. And then by day 5, what we like to see is what we call blastulation, or development of a blastocyst. And that's where we then see 2 distinct cell types, the cells that are going to become the baby and the cells that are going to become the placenta and the membranes. Because of Jerry, we have something called the Grow app. Grow is where you can actually watch images of your own embryos as they're growing in the lap. You don't have to do it. It does not cost anything. It's a free service, but some people don't like it. So it's basically an opt-in thing where the evening of the day after your egg collection, you'll be sent a link. And if you want to, you just follow that link and set up a password, and then you'll get images of your embryos sent to you. So not all eggs will make embryos, and not all embryos will be usable embryos. So looking at this graph gives you a bit of an idea of what the fate of embryos is with an IVF cycle. So if we start with eggs first, not all of those eggs will be mature. Not all of those mature eggs will fertilize. Not all of those fertilized eggs will grow to the right stage of development by day 3, which would be about 6 to 8 cells. Not all of those embryos will make day 5 blastocyst embryos. Not all of those will get to transfer, and an even lesser amount get to be frozen embryos. So a lot of couples come in expecting that every egg will give them an embryo, and that's absolutely not the case. Most couples, we aim for 1 embryo out of any IVF cycle. About 40% of the time we will get excess embryos to freeze. So not everyone gets excess embryos to freeze from an IVF cycle. A lot of people get concerned about, well, how do I know once my genetic material, my eggs, my embryos, my sperm, etc., go into the lab that I am getting back my own pregnancy, my own embryo for a pregnancy? We have substantial double and triple checking at every single step along the way. So there's two-factor identification with two humans checking everything. Plus, we have something called GIDI, which is the Genea identification device, where basically it's also using RFID technology to be doing checks at every step as well. So once we've got the embryo, how do we put it in? Basically, it's something called an embryo transfer. It's usually done on day 5 after the egg collection, or at a later date for a frozen embryo transfer. And basically what we do is we put a speculum in the vagina, just like when you have a pap smear. A very thin catheter goes through the cervix into the uterus, and there's two catheters. So there's an outer one that just goes through the cervix, and then an inner one that advances into the uterus itself. Once the doctor gets it into the right place, and we use an ultrasound to guide the placement, because these catheters have a little echogenic tip, so we can actually see where they're going within the cervix and the uterus on the ultrasound. We then hold that still, and then the scientist will actually do the injection, and they will inject the embryo into the catheter. We then check that the catheter is empty of the embryo, so the catheter is handed back to the scientist to be checked to make sure the embryo has left the catheter and is therefore in the uterus. And then we remove the speculum and it's done. So it's quite a quick procedure. It's given a 15-minute time slot, and oftentimes it's even less than that. So it's quite a quick, simple procedure. This is our embryo transfer room. So there's obviously a bed for the woman to lie on. There's an ultrasound machine for us to check where we're going. And there's another crib in there. So another incubator to keep the embryo at ideal temperature while it's waiting to go in. And you can see that there's a TV screen up on the wall. That's because the crib has a little camera attached to it, where basically an image of the embryo is then projected up onto the screen. So when the patient comes in to have their transfer, they can actually see a picture of their embryo up on the screen before we actually put it in. If we need to freeze embryos, then that's done either on day 5 or day 6. So anything that's not suitable for freezing on day 5 can be checked again on day 6. And then we can therefore use that in subsequent attempts at pregnancy. So all patients will then use progesterone support. So this is usually vaginal progesterone supplementation, but sometimes can be injections. And then a pregnancy test is taken 13 days after the egg collection, so 8 days after the embryo transfer. That can often be a really hard time, because you're just sitting at home waiting for 8 days. Your contact with the clinic is minimal over that time frame because there's no tests being done. And a lot of time it's really nerve-wracking just sitting around waiting for that. Whereas the other times there's been lots of, medication to think about, or tests to do, or procedures to do. So as Brooke explained, we're in Merriweather. We're a small, really tight-knit unit where everyone knows each other and works really well together. And this has led to substantially high success rates in our unit. Just a quick word on donor sperm. If you are needing donor sperm, either as a single person, a same-sex couple, or a heterosexual couple where there is no sperm, where the man doesn't have sperm, we have 3 options. So we have what we call known sperm donation. So that's where the patient has a friend or an acquaintance who has agreed to be a donor, and you know who each other is. Or there's what we call unknown donor bank sperm. So that's either through the Genea sperm donor, which is Australian recruited donors, or we have access to some overseas sperm banks, so the European sperm banks, or Fairfax Cryobank, which is in the US. Egg donors, we also do egg donation cycles as well. That can either be for women who have already undergone premature menopause, or women whose eggs have proven to not be of good quality and not leading to pregnancy. finding an egg donor can be a bit of a process. Most women need to find a donor themselves. However, sometimes there are donors recruited through Genea. Usually the fertility specialist will have sort of advised egg donation, and then our counsellor Tony and our nurse coordinators Sally and Jess will often help and guide patients into how to go about the process of finding a donor. And then once a donor is in place, then counselling is done, treatment for the donor with an IVF cycle to collect their eggs, and then eventual embryo transfer for the recipient person. So I'm just going to go through some things that are asked frequently. So a lot of people say, well, what can I do to help optimize my fertility? Definitely timed intercourse is helpful. Some couples come and go, oh, we maybe have sex twice a month and we don't really try and time that within the fertile window. So that's going to reduce their overall chances of achieving a pregnancy. So trying to time that is helpful. A healthy diet, regular exercise, and that goes for both the woman and the man. Folate and iodine supplementation, avoid smoking and alcohol consumption, and reduce caffeine consumption to 1 to 2 coffees a day at maximum. We've discussed this a little bit at the start, but who should see a fertility specialist? So if you're under 35 and you've been trying for 12 months, over 35 and 6 months, those with a history of recurrent pregnancy loss, those who have a known diagnosis that might impact their fertility, such as endometriosis or PCOS, couples with a known genetic condition that they know they may pass on to their offspring, same-sex couples wishing to pursue pregnancy with donor sperm, single women wanting to start a family with donor sperm, and anyone who just wants to assess their fertility. A lot of people ask, well, if I have eggs or embryos in storage, well, how long can I keep them in storage for? The simple answer is as long as you want to. The default consent times are usually 10 years, but that does not mean that you have to use them within that 10 years. And if you wish to continue to keep them in storage after that time frame, that's definitely possible. Different clinics have different default lengths, but Genea Newcastle is usually 10 years. Does IVF use up my eggs any faster than what I would do on my own? I did go into this a little bit when we talked about the IVF cycle, but basically the answer is no. We are only using eggs that would have been recruited and lost that month anyway. Does IVF increase my risk of cancer? The answer is no. There's been many, many long-term studies on patients who have undergone IVF, and there is no increased risk in any future cancers. So just a little bit about Newcastle Fertility Specialists that I mentioned earlier. So we're 4 female gynecologists all doing infertility. So there's Dr. Kate Burston, myself, Dr. Mufami McElveen, and Dr. Angela Dunford. We can offer appointments within 4 weeks and often less than that. Dr. Dunford and I usually have availability within, Dr. Burston and I usually have availability within about 2 to 3 weeks. We offer in-person, we offer telehealth, we offer hot docs appointments. Sorry, I've just got a tickle in my throat. We all offer a full range of different services, so egg freezing, ovulation induction, tubal patency testing, treatment of endometriosis, IVF and surrogacy. We all operate at Lingard Private, and Dr. Burston and Dr. Dunford also work at the public hospital, so we do have access to public operating lists. Dr. Burston also travels to Port Macquarie once every 4 weeks to consult in person up there, and Dr. McElveen travels to Gosford on the Central Coast every 4 weeks to consult in person there. So there's also other options for people who don't live in Newcastle. So the Genea team consists of our nurses, our embryologists and andrologists, our accounts team, our reception team, our sonographers, our counsellor, our document control officer, and obviously us fertility specialists. So there are a reasonable amount of us, but it's, again, as I said, a tight-knit team who all work really well together. So I just wanted to mention something called Your IVF Success website. So this is a government-funded website where our regulatory body, which is ANZARD, where we have to report back the outcomes of every single IVF cycle that we undertake. So that information that all clinics have to report back to ANZARD is then put together by this government organisation and published, where you can then look at an individual clinic and you can look at their success rates compared to the national average, and you can also compare them to other clinics in the area in case you're trying to choose a clinic. We have been extremely happy with the publication of Your IVF Success, because we always knew that our success rates were very, very good and one of the best in Australia, but we are not allowed to advertise that, and now you can actually access this and see it yourself. It also has a personalised IVF success rate estimator, so you can plug in your own personal details and get some idea of your potential chance of success. I will put in, though, that's kind of based on national average, and success rates in our unit may be higher. So that's all I had for my presentation. I'm going to stop sharing that now, but very happy to answer any questions that anyone has, if anyone has anything.